So the plan is today to finish up the balance of the urinary system. Can you hit that which is really the rest of the system, okay? So the ureters, the bladder, the urethra, and then the Micturition Reflex. So clearly the bulk of this chapter's material is in the kidney and particularly in the nephron and how it works. And then we'll start in on the chapter 24, the fluids and electrolytes chapter. Okay, so I like this picture. This is the kind of thing that you will get the opportunity to see in healthcare from time to time because our skills with x-rays and other radiologic procedures just keep getting cooler and cooler, right? So what this is this is an x-ray study where the patient has been given an IV substance which actually lights up under X-ray. It shows it's radio opaque. In other words, it shows white on a classic X-ray. And then they've taken it and they've colorized it a bit so that you can see the distinctions between the different shades of white. You know, shades of white is hard. Shades of color, our eyes are much better at that. Okay, so what you see here is this IV medicine enters the kidney and it's immediately put into what will become the urine. So it sequesters in the urine. So in dark orange here, this is the collecting system of the kidney. So these are the minor calyces, right? Here's a major calyx. Here's another one. This is the renal pelvis right here. Okay, so anatomy from, now it's been almost 2 weeks, but that collecting system anatomy. And then we see it on the other side. Here's the kidney, which is lit up a little bit in this because it has that radio opaque dye in it. And connecting to the pelvises are the ureters, right? The ureters are pretty long and straight. They do follow the curvature of the spine, which is why you see this little bend right here. It's because that's where the sacrum goes towards the back. It goes posterior. So in a front picture like this, it looks like they curve. They really go straight, but they follow the curve of the sacrum all the way down. So they're very far back. They sit really right up against the spinal column, the front part of the spinal column. And then here's the urinary bladder. This is a full bladder, okay, because oftentimes with these studies, we want to see what the bladder wall looks like. So, you know, we ask the patient not to urinate for a time, and their bladder gets very, very full. And we can see that here too. So this is a full bladder. This is where the ureters enter that bladder. So this is the urinary storage and elimination system, sort of in a picture. All right. What we don't see is down here we have where the bladder connects to the outside world, and that's through the urethra. All right. So looking at the bottom of this picture, so we're going to look at this area and below here. We see some pretty significant differences in the urethra of the male versus the female, and to some extent in the size of the bladder as well. Okay, so here's the urinary bladder in the male. Here it is in the female. Now, it looks very different. This is a more full bladder than this one is. Okay, so when the bladder fills, it expands up, okay, into the abdominal cavity. Because that's really the only place it can expand. Because to the bottom is bone, right? So this is the pubic symphysis here. Wrapped around here is the pelvic crest. And then we have this connective tissue and reproductive system stuff in the floor of the pelvis. So really the bladder can only go up. It can't go down. So what we see here is, see, this dome is sort of convex, right? And this is sort of flat. It's because this bladder is more full than this one. If this were to empty, it would have a more flat profile too. So the bladder size between male and female, the bladder is larger in the male, but not by much. It has more to do with person size than it does gender. So, you know, a large, tall, heavy-bodied person, you know, a wide person, will have a larger bladder than a smaller, thinner person will have. Much more so, that matters more than the gender of the patient. Okay? All right, so here is where the ureters come in. They connect at the back. And here the ureters would connect right about here. Better picture of that in a minute. And what you don't see in this picture is the ureter actually connects to the bladder at the bottom. All right, it looks like it connects at the top, but it doesn't. The tube, the openings are actually down here in the bottom. I'll explain why that's true in a minute. Okay, but the biggest difference you see is the urethra difference. So in the female, the urethra is short and straight, right? In the male, it is long and winding. Okay, so that gives two different profiles for urinary tract issues between the male and female. The short, straight urethra and its proximity to the bacteria in the vagina and near the anus means that urinary tract infections, particularly bladder infections, are much more common in women than they are in men. And it's because bacteria have an easier time making this short, straight journey than the long, winding journey in the male. Okay, so it's a so urinary tract infections are much more common in women. Now, in the male, though, the urethra is shared between the urinary system and the reproductive system. So that opens up a whole other set of possible disorders where reproductive system disorders can affect the urinary system. And the female doesn't have that, right? The female, the systems are separate. In the male, they're combined. And one area of particular clinical relevance is this right here. This looks like a circle in this picture, but it's actually a two-lobed semi-spherical gland. This is the prostate gland, and it surrounds the urethra. Okay, so here's the bladder, here's the urethra passing through, and then into the base of the penis right here. So the urinary urethra passes through the prostate gland. Now, why does that matter? Because prostate gland problems are common, very common, in fact. What happens as men get older is their prostate glands have a tendency to swell. They get larger. And as you can see, there's really no room for it to get bigger because it's surrounded on all sides by other stuff. So what happens is as the prostate gland hypertrophies or gets to have more cells in it, this urethra passing through it gets squeezed shut by the prostate gland pressure around it, which means that a lot of men will have what's called BPH, like here, benign prostatic hypertrophy. This is where the swelling of the prostate gland makes it difficult for urine to pass from the bladder to the urethra. So you'll hear there are now medicines for this, and you'll hear about them on television sometimes. They'll talk about hesitancy or difficulty beginning urination. That is usually benign prostatic hypertrophy or prostatic cancer. The prostate gland becomes cancerous in a large percentage of men too. Some would even say that if you live long enough, a male will always develop cancer of the prostate if they live long enough. Now, the jury is still out on whether that's true, but it certainly is. The older you are, the older the male, the higher the risk of prostatic cancer, which it's not a particularly aggressive cancer, but because it's so common, it does result in many deaths every year because many men have that. All right? So some differences in the two systems. Okay, so let's look at the bladder itself. Remember how I said that the ureter is actually empty into the bottom? Well, here the ureter is coming down, and it looks like they join at the top, right? But they don't. They actually continue along the side of the bladder, and the holes are here and here, so they enter at the bottom. If you think about how the bladder works, this makes sense. This is a very full bladder. Well, a very empty bladder, its roof is going to be right here, right? So you can't have the openings at the top if the top is going to move, if it's going to get full and then empty. So instead, the bladder fills sort of from the middle or from the bottom, okay? And so we have the two ureter entrances, ureter openings. Then we have the exit, so here's the urethra. And remember, this is a three-dimensional structure. So this area right here forms a kind of funnel. Okay, so it's in actual shape, it's sort of more rounded or conical in its shape. And in between, the triangle that's made between the ureter openings and the urethra it has a real smooth epithelium on it, something you can really see in the living specimen. So it gets a special name. We call that the trigone, is this smooth funnel-shaped area between the ureter openings and the entrance to the urethra down here. And then they're just showing you the prostate gland in the male only. In the female, there's nothing there. Okay. So we have two sphincters. Remember how I said there's a lot of similarities between defecation and micturition? Well, it starts here. We have an involuntary internal sphincter and a voluntary external sphincter. Same pattern as we saw in the anus. Okay. The internal sphincter is way up here at the base of the bladder. And the external sphincter is as part of the pelvic, we call it the pelvic floor. The bottom of the trunk of the human being, there's no bone right at the bottom. Think about the skeletons up in lab. You can look right through their pelvises and onto the floor, right? So, what holds our insides up and not falling through that hole all the time? Well, we call that the pelvic floor, and it's a set of muscles that traverses the space between the pelvis and the sacrum in the back. So this region right here is the pelvic floor. And in the female, this region right here is the pelvic floor. Okay? The muscles of the pelvic floor, one of the places you'll hear people talk about these is in the Kegel exercises, many people will have heard of. Those are exercises to strengthen the pelvic floor. Because one of the things that happens, particularly in women, is this pelvic floor really gets stretched to the max when a baby is born, right? So here's where baby comes out through here. Well, baby's head is about this big, right? Just small enough to fit through the bones, which means that the pelvic floor gets stretched open, and that can cause problems after pregnancy or even much later in life, 50, 60 years of age, with organs wanting to fall out through that stretched and weak pelvic floor. So one of the recommendations is keep these muscles strong. They'll stretch more easily, and they'll go back to their original condition, and they'll stay strong, and you won't have organs trying to fall out through the bottom of the pelvic floor, right? So you all, when you have babies, if you haven't already, will be told all about Kegel exercises and how to strengthen the pelvic floor, right? And many of your mothers, grandmothers, if they're being honest, they might say that sometimes the urine doesn't stay in the bladder like it's supposed to completely. Urinary incontinence or dribbling, that again is because baby pushing its way through here pretty much messes up this nice intact pelvic floor, including the external urethral sphincter right here, which once it gets stretched during delivery, you have to work at it to get it back strong again. Okay, because when you stretch these muscles like that, they don't want to necessarily go back to their original condition. So those of you considering having babies later, now you're all like, is that something I really want to do? All right, so we have an internal sphincter and an external sphincter. Yes?
Can you go back to that picture?
That one?
How far up does a catheter go in the urethra?
In both. Ultimately, you want the tip of the catheter in the bladder itself. Okay? This is why catheterizing a male is a significantly different thing than catheterizing a female. Because in a female, you've got a short, straight entry into the bladder. This is a grand total of probably 4 inches right here. Now, the more difficult part, as many of you will learn, is you have to make sure you start in the right hole, right? Which seems silly, but it happens all the time to young nursing students, physician assistant students, anybody who's never started a catheter before. There are often, I don't get any urine out. Well, it's because you're not in the right hole, right? Now, in the male, you've got a couple of more problems. 1, you've got a longer path. 2, you've got 2 bends, right? So when you put a catheter in a male, you have to be aware that there's resistance right here as the catheter has to make this first bend, and then there's resistance right here as it has to make the second bend on its way up, right? So yes, the tip of the bladder the tip of the catheter should be in the bladder.
Is the diameter of the urethra similar in both male and female though?
It is. And you can kind of see that by scale here. Now, in the male, the urethra, it gets a little larger as you get further in, but they're about the same size. Now, you have to remember the bladder or the urethra is by nature an elastic tube, too. So, like, when you see a urinary catheter, you might think, my gosh, that's huge. How can we put that huge thing into it? But this stretches, okay? And it does so during urination, too. The urethra actually relaxes and gets larger during urination. So when you go to put a catheter into a patient, one of the things you try very hard to do is to make them be relaxed, because the more anxious they are, the tighter the urethra squeezes, and the more difficult the procedure. So yes, good question. An alternative way of getting bladder or getting urine from somebody is to put a needle into the bladder up here over the top of the pubic symphysis. We call that a suprapubic tap. And we do that oftentimes in kids because it's far less traumatic to stick a long needle into the bladder than it is to put a catheter into their bladder. So we have options. Depends on what you need the catheter for, though. But if all you need to do is get urine, you can do that with a needle through here, too. All right, good questions. Okay, so the Micturition Reflex has a basic part and a complicated part. Neurologically, I mean. Really, they're no more complicated to look at. But so in purple here is the basic part. This is what we have when the day we're born, even before we're born. And this is the non-conscious, non-controlled pathway for micturition. Micturition is just the fancy name for urination, or voiding is the common word we use in the hospitals today. Has the patient voided, or are they voiding? The whole system starts because of stretch. Okay, the kidney is making urine all the time. It doesn't stop, it's always making urine. So there is always urine flowing from kidney to bladder. Now the rate at which urine is formed does vary. You know, if you are on if you haven't had very much fluid, for example, then you make less urine, but it's more concentrated. You know, we talked about that last time. But the kidney's making urine all the time. So if we started with an empty bladder, the kidney fills that bladder slowly over time. Well, as it fills, the bladder relaxes and gets bigger, similar to what the stomach does, right? It relaxes itself into getting bigger. It isn't stretched like a balloon. It gets bigger like an expanding bag does. Okay. But eventually it's gotten as big as it can get, like this. But the kidney is still adding more urine to it. So at some point it does start to stretch like a balloon. And when the smooth muscle in the bladder stretches, it sends a signal to the spinal cord saying, essentially, bladder is full. Okay? Now, that signal goes to the spinal cord and then it splits. A signal from the spinal cord back to the bladder, so you have this is a reflex loop, right? So into the spinal cord and back out, no brain involved. Well, that signal says the bladder is full, contract the bladder. Okay, so now you've got the full bladder. Now it's going to start to squeeze. So you've got a squeezing bladder and closed sphincters. So that is what creates the urge to urinate, or that urinary pressure. Because there actually is pressure, because the stretch has resulted in contraction. Now, why on earth does that make sense? Why contract the bladder if the sphincters are closed? Well, in the case of not conscious control, in other words, an infant or somebody who has had significant neurologic insult, that's all there is to micturition. Bladder gets full, bladder contracts, bladder empties, right? So nice, simple loop. When the bladder gets full, it squeezes itself smaller, and the urine leaves. So this is what happens in babies. You know, even though babies have a diaper on and they are not in control of their urination, they don't urinate a little bit all the time, right? As anyone who's taken care of an infant will know. Instead, their bladder fills and empties, and then fills and empties. Just like it does as an adult, they just don't choose when it empties, okay? So that's the purple loop, is the unconscious pathway. Now, when that signal of stretch occurs, Another signal is sent up to the higher centers of the brain. So through the spinal cord, up through the thalamus relays it up to the cerebral cortex of urinary pressure or full bladder. Now, the cerebral cortex then has a decision to make, as the book says. If it's convenient for urination to occur, then the brain sends a signal back down here to the sphincters to trigger that urination. If it is not a convenient time to urinate, then the brain does not send that signal, and this system eventually resets so that squeezing bladder stops squeezing. Now, the urine is still in there, right? The bladder is still pretty full, so it's not going to be long after that whole process is going to start again. Okay, so the internal sphincter is involuntary. The external sphincter is voluntary. Okay, now, this is where it departs a little bit from the defecation reflex. What happens is relaxing the external sphincter triggers the relaxation of the internal sphincter. So when this one relaxes consciously, this one follows along unconsciously. Once you have both sphincters relaxed, the bladder is already contracting, right? So it's going to push that urine out through the urethra and out into the rest of the world, right? Out into the world. So we have similar features, an internal and external sphincter. We have that in both defecation and micturition. We have a higher pathway and a simple pathway in both things. The only difference is in the pattern of relaxation of that internal versus external sphincter. So in micturition, the external goes first and then the internal happens. In defecation, the internal sphincter relaxes and then the external sphincter gets control, and then that's how that system works. So you can compare those two. All right. Yes?
Can the bladder rupture?
Not unless there is a problem beyond the brain. Okay, so in that benign prostatic hypertrophy, for example, let's say the prostate gland was so swollen around this urethra that it could not empty. Not that the person doesn't want it to, but can't. Physically, there's no space. Then yes, the bladder can get so large that it breaks. But a more common thing that happens is all that pressure backs up into the kidney. So pressure here becomes pressure here, becomes pressure here, and the kidneys stop making urine, which is a bigger problem. Because now you've got, because it becomes capsular hydrostatic pressure, so it stops filtration if that goes on for too long. Yes?
Would your body actually let that happen, or would it make you pee with your literally?
No, the only time that can happen is if you can't get the urine out.
Oh. Okay.
In other words, there's a physical obstruction.
Okay.
You're not going to be able. Nobody has that kind of willpower.
Okay.
Right. In the end, the bladder wins.
Right.
If the bladder can empty, it will before it's damaged.
Okay.
But in the case of some physical obstruction, other things can happen.
Got it.
Or, for example, let's say you've got a catheter in a patient, and the catheter's got a big fat blood clot on the end of it. Then you've got the same problem. The bladder cannot empty because there's no way to get the fluid out, the urine out. Good. All right. Okay. Not very many questions, but during the micturition reflex, which of those things is true? Don't worry about the Socrative. I've probably given up at this point. What do you think? Here, E, anybody else? Yeah, it's E. The C would be fine if it was external sphincter, but the internal sphincter is urinary or is smooth muscle of the bladder. So we have no conscious control over that. But the other ones are true. So parasympathetic, okay, not only is parasympathetic rest and digest, but it's also the principal player in micturition and defecation too. So just know it's parasympathetic, not sympathetic. All right. And that's the end of that show, right? Okay, so any questions about the urinary system? The thing I want you spending the most time on is the nephron, okay? Because that's the real business end of it. And when you get to further classes, you'll find that the rest of the story, so to speak, on renal physiology, it gets really complicated. So having a good solid foundation of the nephron, its parts, and what those parts do is going to help you tremendously when you get to those upper level classes. Because just like the liver, we kind of glossed over it because it's so complex, all the things the liver does. Well, the kidney is a pretty complex organ too, and we just sort of scratched the surface of what it does. But it does a very good job of taking care of our metabolic levels of things, getting rid of things we don't need, holding on to things we do, and all that. Okay. Because it's a really good segue to this chapter 24. Because fluids and electrolytes and acid base are all things that have to be right pretty much every moment of our lives. Okay? Because all of our physiologic processes depend upon these three things. Fluid, electrolytes, and a proper pH to function normally. Now, the kidney plays a role in all three of these, but the role of all three of these extends well past the kidney. Okay, so similar to our metabolism chapter, chapter 24 is a little different than we've been looking at the body. We've been looking at it organ system by organ system. And we're going to finish that way too when we get to the reproductive system next week. But chapter 24 takes a step away from the organs and looks at the body as a whole organism in relation to these three things. Okay, so fluid balance is where is the fluid in the body, how much fluid is there, and the relationships between that fluid and its location. Now that may seem simple, but of all of the things that people when patients are in the hospital, okay, fluid balance is something you look at in every single one of those patients, okay, because you've taken that patient out of their normal environment and you've put them in a new environment. So one of the things you have to be worried about is their fluid status. So all of you that are going to take care of patients, human or otherwise, every day that you're taking care of a patient in the hospital, you're going to think about fluid balance. Okay, so it is, all three of these topics are like this. They're hugely important. Okay, so fluid, very important. Electrolytes is another thing that you're going to follow patients in the hospital for every day. Also, all three of these things are things people end up in the hospital for because something is wrong with their fluids, their electrolytes, or their acid-base balance. So, take dehydration, for example. Somebody's had dysentery and they've had diarrhea for several days. They may need to spend some time in the hospital to get fluids and electrolytes fixed, and maybe even their acid-base balance addressed. So these are little things that make a big, big difference or big impact on the patients. Okay, so electrolytes are ions. They're also called minerals oftentimes because they're found in mineral form in the environment. And then acid-base is the body's pH. And as I've mentioned before, our bodies are particularly sensitive to pH change. If you have a pH of 7, you're probably going to be hospitalized, maybe even be in the ICU. So 0.4 difference, and it's that big of a deal. Typically, patients, you know when a patient is on the death spiral because their pH is very, very low, is one of the signals that you have a very sick, potentially dying patient. So pH is critical like that. And then we're going to look in this chapter at kind of the interplay between some of the systems we've already heard about. So cardiovascular system, renal system, respiratory system, and digestive system all play a role in all three of these whole body issues, right? Okay, so we start with fluids. The classic, well, what are we made of? Well, we're made of, for males, it's about 60-40. For females, it's about 50-50, water and other stuff. Now, where is that water and other stuff? Well, it's distributed into two compartments. And this compartment model is particularly useful, so we're going to look at it sort of in detail. All right, so we have, here's the water out here. This is all the other stuff, okay? So this is the solid bits of us. You know, most of this is muscle protein, bone, and the connective tissue makes up these solids. So the fluid is divided between water in the cells and water everywhere else. So ICF is intracellular fluid. And I know you've heard these things before, but I don't want you to be confused. So we're going to cover all the letters here. Intracellular fluid and extracellular fluid. Now, there's only one intracellular space, though. So all intracellular fluid is just that, intracellular fluid. There's no other compartments. For extracellular fluid, though, there is. Okay? Outside of cells and outside of the blood vessels, we call that interstitial fluid, not to be confused with intracellular fluid. Okay? So a picture. We have a blood vessel, right? We have cells. Okay? So, and then we have water. So inside of cells, we have intracellular fluid, right? Around cells, we have interstitial fluid. So that's all this stuff, okay, right? And then inside vessels, we have plasma volume. So plasma volume is outside of cells. So the plasma volume does not include the fluid inside red cells, for example, right? Inside red cells, that's intracellular fluid. But if you're in the blood vessels and you're outside of red cells, that fluid is called plasma, as we learned in our second chapter together, right? So we call that plasma volume. Okay, so both of these together are extracellular fluid. You see how that gets a little confusing? So you've got fluid inside of cells and fluid outside of cells, but then that fluid that's outside of cells is in more than one place. And this is not being trivial. The difference between interstitial fluid and plasma volume is a pivotal one for fluid balance in people. Okay, so for example, if I were to give you a liter of pure water, okay, I would dramatically alter the ratio between plasma volume and interstitial fluid volume in you. Because what would happen is that pure water would have a tendency to dilute your interstitial fluid and cause fluid shifts, as we'll talk more about in a minute. Okay, so the different parts, the different types of fluid, which I have a better box for, I think, coming up. Yeah. Okay, so what are the solids? Proteins, lipids, mostly. Proteins, that's your muscles. Okay, muscles have a lot of solid to them. You know, as you find out in the kitchen, if you've prepared, you know, food from an animal, you know, protein is a solid. Lipids are a solid, and they don't dissolve well in water, so they stay separate. You know, like our skin, for example, even if you have very little body fat, the layer under your skin is still a significant component of your weight to help keep you warm. So that's lipids. Minerals, those are your bones mostly. And then carbohydrates, we have some of that in our bones. We find a lot of that in our connective tissues. So these are all the parts that are not dissolvable in water. All right. So ultimately, because of, you know, the conservation of matter, law of physics, the amount of water that goes in and the amount of water that comes out has to be about the same. Otherwise, we have fluid retention, right? Or we have dehydration happening. That's not going to explode. It's just going to whistle at us for a minute. Okay. So we can look at a patient's fluid balance by looking at what we call the ins and outs. And you know, anybody who's in the hospital is probably having their ins and outs followed, at least for a time, because it's a great way of assessing a patient's fluid balance. Okay, so the ins are what go in, obviously. So in a typical diet, that's about a liter of water in the food that we eat. Most food that we eat has some water in it because we can't taste anything without water in it, and most of the cooking that we do involves water. So that works out to be about 1 liter. 1.2 liters is consumed as a liquid, so that's water you drink. Now, this varies according to the person. Some people are very good at staying hydrated, and it can be twice that in some. And then we actually make a little bit of water too, which often surprises students. So in the process of breaking down carbohydrates into carbon dioxide, we form water as part of that chemical equation. So we produce some water from the food that we eat too. Very similar process to what you find in a internal combustion engine. So sometimes on warm days you'll see water coming out of somebody's tailpipe in front of you. It's because water is a byproduct of combustion of carbohydrates, and our cells have that same byproduct. Okay, so all told, that's about 2,500. Now, how do we get rid of it? Well, about 1 liter, 1.2 liters, is through urination, in the formation of urine like we've been talking about. And we get about 150 lost out from the digestive tract in feces. Okay, so that leaves a big chunk though, okay, so that's 1,350, so we're still missing 1,150. Well, these two, the evaporations, these are what we call the insensible losses, because we can't really measure them, at least not without going to great extremes, okay? So evaporation happens all the time, but it isn't measurable. So what that means is in the hospital, you always have more fluid going into a patient than you can measure coming out. So don't fall for the mistake of, shouldn't a patient's ins and outs, the amount of intake and their amount of output, be the same? Never, right? Because the outs is not the whole story. There should always be more in than out to account for the insensible losses, the things we can't measure. Okay, because all the time, we're evaporating water from our skin, helps to keep us cool, and every time we take a breath out, some water goes with that breath, so we lose some at the lungs too. Now, these two can also change pretty dramatically. If you have a fever, let's say, you're running 103.5 degree fever, well, these are going to be double that, because you're going to sweat more, your temperature's higher, you're going to evaporate more, you're going to breathe faster. So in a patient who has a fever, you need to account for that change, even though you can't measure it, right? So you give more fluids to a patient who has a fever than to a patient who does not have a fever. Similarly, respiratory distress, let's say you got a pneumonia, you don't have fever, but you're breathing 60 times a minute. That too is going to dramatically increase your water loss at the lungs. You're not going to be able to measure it, but you're going to need to make sure that you're accounting for it in that patient's fluid balance. So those are just some examples, okay? So these evaporative losses are difficult to measure, but we have to remember they're there. All right. Okay. So as we saw in that slide 3, we've got intracellular fluid and extracellular fluid, and that extracellular fluid is in 2 places. Oh, I didn't talk about the 1%. Hold on. Some of you detail-oriented people would think, well, what about this? What about the other bodily fluids? We have a few other fluids in the body that are not blood, okay, and are not interstitial fluid. One of those is cerebrospinal fluid, right? It surrounds the brain and spinal cord. All told, there's maybe 250 mLs at any given time, so there's not much there. We have a small amount of pleural fluid in the pleural cavity, small amount of peritoneal fluid in the peritoneal cavity, and we have a small amount of fluid in our inner ears. Remember that from last semester? So all those together doesn't even make up 1%. Okay, but that's the other. Mostly we talk about these two, interstitial fluid and plasma volume, both of which are extracellular fluid. All right? So when we think about the patient, we have to remember that the water or the liquid that we can measure about the patient is this compartment, okay? It's pretty difficult to measure what's going on inside of cells because we don't have a million tiny little needles to sample the inside of cells with. Instead, what do? Well, we take blood out of their arm. Okay, most of that fluid in that blood is extracellular fluid. So this is what we can sample, but the intracellular fluid is much larger. You see that? So about 2/3 of the body's water is locked away inside cell membranes, where we can't get at it to sample it. Now, thankfully, our bodies make it pretty easy to tell what's happening in the inside of cells by looking at the fluid outside of cells, because things are being exchanged all the time from inside of cells to outside. All right. So this is giving you an example of how water readily moves between these two compartments, from inside of cells to outside and vice versa. Okay, so here we've got a normal. Now, we're going to take away a bunch of extracellular fluid. Now, how would we do that? Well, if, let's say you gave blood. Okay, that would be this example right here. Some significant part of your extracellular fluid went into the now red bag that they're going to take to the blood bank. Okay, so what happens to you, the patient? Well, we've taken this away. Because water can readily move between the two compartments, the water inside your cells, some of it, is going to move outside of your cells until the two are in balance again, right? Until the two have the same, not the same volume, but the same pressure, essentially. So, yes, you gave blood, but some of that water is replaced by water that's inside your cells. Now, this can work in reverse, too. So, you followed the directions of the person at the blood bank, and you're drinking plenty of fluids the next couple of days after giving blood. So now you're putting extracellular fluid in here, and it goes into the ICF space, too, until you get back here, until you get back to normal. So, because water can readily move between these compartments, we can assess the intracellular space by sampling the extracellular fluid. Okay? This is one of the cornerstones of laboratory science. If we couldn't do that, if the inside of cells and the outside never communicated, we would have a much more difficult time figuring out what was happening with the patient, because we'd have to break open a bunch of cells in order to find out what was going on inside them. All right. All right, so that's the introduction to fluid balance. Because we start tying these things together in a minute. Probably next time. So the introduction to mineral balance or electrolyte balance is very similar. Just like we can't make water out of nothing, we certainly can't make our minerals or electrolytes out of nothing either. And it's even worse, the electrolytes are not really metabolically active. In other words, we can't make sodium from something else. We have to have it in our diet. We can't make calcium from something else. These are elements. Our body doesn't do nuclear fusion. So we have to get it in our diet, which means there's a similar balance between intake and output. Okay, so where do the ions come from? Where do these electrolytes come from? They come from our diet. So most of what we eat was once alive and shares many of the same mineral requirements as we do. So, for example, sodium, potassium, calcium, magnesium, all of those common ions are present widely in food that we eat. So, our source of ions in our to support our own electrolyte balance comes from the food that we eat. Ions are very readily absorbed by the small intestine. They don't have to be digested like the nutrients, like carbohydrates, proteins, and lipids do, because they come in their tiny little atom form already. So you can't break them down. They're atoms, charged atoms. So we absorb them first into the intracellular fluid through the epithelial cells of the small intestine, but then eventually they get into the extracellular fluid too. Now we also have mineral storage, which we don't really have for fluid. We are not like the desert animals, like the camel, and that has a way to store water outside of the regular circulation. But we do have a way to store minerals outside of their regular use, and that's in the bones. So bones are made of, calcium mostly, but also sodium, potassium, magnesium, and some other rarer elements. So if we take in more ions than we get rid of, well, we can store them in the bone. We saw this when we talked about parathyroid hormone and calcitonin, right? How the bones play a role in calcium homeostasis. So that's what they're talking about here. Well, if we take ions in and we don't store them all, well, that means we have to have some way for getting rid of them too. Most ions that we take in eventually leave the body from the kidneys. So the kidneys are always producing urine that has sodium, potassium, calcium in it. And depending upon our dietary intake of those things, the kidney can either increase or decrease its excretion so that our intake and output matches, so we stay in electrolyte balance. And in the human beings, with our fancy sweat glands, we lose some sodium chloride through sweat as well, because there is sodium chloride in our sweat that then evaporates. Now, strangely, the salt actually evaporates with the water because there's such small amounts. But if you do a lot of sweating over a long time, you'll actually get salt in your skin from that evaporation, leaving the sodium chloride behind. All right. So the only ones that are stored here are calcium and phosphate. The rest of these are just the balance between intake and excretion. All right. So we'll stop there for today, and we'll talk about the specific minerals and stuff tomorrow.